Thank you very much. As you can see, we've had a bit of a whistle-stop tour around the world, really highlighting how we've moved from an era where there wasn't really very much interest in cholangiocarcinoma to now quite a lot of activity. Do please feel free to come to the microphones with any comments or questions, but just to get the ball rolling while people are coming to the microphones, I want to just, Laura, just to pick up on a thought, maybe I'll work backwards. You've talked about a lot of studies and increasingly successful studies that have recruited very well. Have there been any, and each of the studies will have increasingly a translational program, tissue acquisition, a number of different samples. Are there any thoughts around having a sort of cross-cutting platform of omics that is standardized, goes across the studies, and is able to kind of accelerate some of the work rather than being individually study-based?
So I think there are ideas and discussions, but it is sometimes hard to be working in America where people have ideas about everything is their way is the best way, and so I think that is we have gotten to the point where we can accrue together and we can share credit and support, and then I think our next frontier is the best molecular platform. Even in the NCI match, there's sort of a list of options, which I think broadly may ultimately get you some of the same information, but having been on the other side, and I know Lipika can certainly speak to this as well, that on the other side, trying to figure out how to analyze that data on several different platforms, it can be very complex. Lots of people are doing that way, but we need to get there. That's our next goal.
That's your challenge.
Yes.
Okay, and Dr. Budhu, nobody at the mics. Maybe I can ask Dr. Budhu. I mean, previously we've got big collections of tissue, and we've learned a lot in the past few years about sort of genomic signatures of tumors. But largely these have been limited to resected specimens, much less so patients with advanced disease. So how are you addressing that through the Asian Collaborative? Are you still focusing on patients undergoing resection, or is it more patients with advanced disease, and how do you think that might look different?
Yeah, so that is indeed the case. We have mainly looked at retrospective cohorts and mainly resection patients. And so we have started to make a concerted effort to look at some more of the advanced patient population, and more of a concerted effort also to collect biopsies from individuals sort of on a chronological time frame for us to actually look at initiation of disease as well as progression of disease, and to even have those biopsies available, because I think we had a question earlier of why we don't look more closely at some of the molecular profiling in these studies, and some of the short-term answer is that we don't have the specimens available to do so. And so I think moving forward, that's something that we're really trying to look at. And just to follow up on the last question, I think one of the large fields that we're exploring and getting better at is bioinformatics, because we do have all of these platforms that all of the data are being analyzed on, and we need enhancements in bioinformatic tools in order to be able to sort of standardize the data, and that's one way of doing it while still allowing for multiple platforms to be assessed.
And you also talked about differences in some of the racial groups, but also the difference between C1 and C2 types. Which one do you think which pattern is going to drive, do you think, differences in the way patients are managed in terms of treatment?
I think that's a difficult question. Well, I think from our staging right now of the C1 and the C2 group, it's sort of a better way to handle the patient population is to have more of these discrete subtypes to identify specific driving pathways or driving genes or particular markers that we can then assess more robustly in the clinic and actually have targetable, actionable mutations, for example, to follow. In terms of the race differences, I think that's something something that we're just starting to explore in terms of having the populations to do so. Traditionally, we've had mostly a large-scale Asian populations to study in the past, and that is certainly changing now. And so we will have, populations across the world where we can compare and contrast our data, and I think we'll have some very interesting findings, not only among race, but also among different ethnic groups.
Thank you very much. And maybe, Jesus, I can just address one question to you, maybe as the last question of the session. We're used to citing data from registries like the SEER registry, and then we're also used to citing some of the caveats of registry data in terms of granularity, quality assurance, maybe some missing things around subsequent treatments and toxicities, comorbidities, and so on. How do you think that the ENSCA registry is going to be different and address some of those challenges over the past few years?
Well, that's a very good question. For the good quality of the data, you need the monitorization of the data. You need to monitor carefully the data in order to have some conclusions. So this is important. So our registry, what we want to do is to, first of all, try to involve as much of countries as possible. We have some consensus in the information that we have included before we created a first version that was improved after discussion with oncologists, surgeons, etc. So we are contact every center in order to follow up to include the information that we need. And at the end, it's a clinical repository, very important for future collaborative studies. That's the main objective, no? Have information of the current presentation, management and outcome, which is summarized in the slides that I presented, but at the end what we want to have knowledge is of the biomaterial that are in the different institutions that we can use and then correlate with all the clinical information. And that's why, the cost action, this kind of grants will promote, this kind of international collaboration. So it's important the clinical information that's in there. We can get some conclusions, but obviously a lot of questions too. But at the end, it's going to be a good clinical information and then for correlation for future studies.
And it's a very generous grant, the €500,000 over 4 years. But after 4 years, then what? Where do you think that may go?
Well, I think the main objective, first of all, is to boost the network and then expand it to different international institutions. But at the end, I think that the main objective is to finish the grant with several proposals to the European Commission in order to have additional funding, such as the ESCA loan, for example, for South America and Europe. So I mean, it's important the collaboration, but we need to keep pushing in the obtention of fundings and in the creation of real international robust projects. No?
Thank you very much. If there are no questions from the floor, I'd like to... I think there is a question from the floor. Please go ahead.
Hopefully this will be quick. How long have you been targeting the people in Thailand?
So we've been working with several research institutions and hospitals there. So these are individuals that are being seen at those sites. In some of the northern regions, these are very remote villages, and so we have groups of recruiters and clinicians that actually fly into those sites and have sort of recruitment enrollment days where we try to have someone explain the projects and explain what we're trying to do and have people hopefully become interested and want to participate.
The reason I ask this is because years back, about 50 years ago, we had thousands of our military over there in that general area of Vietnam as well. And I was there as well, but while I was there, I never saw any water that was really what I would call clean, other than what was along the shoreline of the ocean. And I was just wondering if there's any relationship presently as far as any research that has anything to do with the water, substance, and foods that were over there in relation to the outcome of this cholangiocarcinoma.
Yes, so that's a really important question, looking at the environmental factors associated with cancer initiation and progression. There are several epidemiology studies ongoing, and the study that I just discussed, the TIGER study, does have a component of it that is looking at environmental exposures, pesticide exposures from the farming community, for example. We also have comprehensive diet and nutrition questionnaires, so we are trying to look at some of those aspects. And in particular, in that northern region where cholangio is very frequent, there's an interesting village where on one side of the river we have lots of people with cholangiocarcinoma, and on the other side of the river there isn't. So there's some sort of a locality disparity that we don't quite understand yet, and so we are looking into those aspects that are related to the disease.
Please go ahead.
I think that our service people in Vietnam and Thailand and in Asia, it's been shown that veterans, even 50 years later, are showing a rise in the numbers of cholangiocarcinoma cases. So given that we have had veterans over in East Asia, then coming home and years later getting cholangiocarcinoma, and the fact that many times we say there's a difference between the ethnicity and racial differences in cases and molecular and DNA. Is there anything going on to compare and profile our veterans who have that with natives in those areas to see if indeed it is really, genetic and et cetera, and the DNA differences are there, or is it the region in which you are infected, so to speak? I mean, I was just wondering.
Sure. So we actually do currently have grant applications to do those types of studies. And at the moment, we have a study in the University of Maryland at Baltimore, recruiting about 2,000 individuals. And a large portion of that recruitment is occurring at the Veterans Affairs Hospital in Baltimore, where those individuals are mainly hepatitis C related patients. And so we are going to eventually be able to do those types of comparisons.
Thank you very much. I'd like to thank our three speakers who I think have elegantly shown there really is global collaboration in the fight against cholangiocarcinoma. And with that, I'd like to close the session. Thank you very much.